to give a talk on testing the Acuity Vision Field and Colour Vision. Dr. Padmalakshmi.
So, good evening, everyone. Am I audible?
You are audible.
Okay. I thank the organizer, Dr. Pani sir, and Department Director for giving me this opportunity. And my topic for today is how to test clinically visual acuity, fields, and color vision. I'll be talking about both in-office and at bedside testing. Visual acuity measurement is an essential part of the clinical examination. Each eye should be tested separately with the other eye covered. Both distance and near visual acuity should be tested. The most commonly used tool for measurement of visual acuity is the Snellen's visual acuity chart. The standard recording is by a Snellen's rotation, which is a fraction. The numerator denotes the testing distance, which is either 6 meters or 20 feet. The denominator is the distance at which the normal person is able to read the letter. A person with normal vision seated at a distance of 6 meters should be able to read every letter from the top up to the bottom of the 6 meter line, and the vision is recorded as 6 by 6. If the patient can read only up to this line OLHA, then his distant vision is defective and recorded as 6 by 18. So how to test? The patient is placed at a distance of 6 meters from the chart. We have the trial frame, which is this is the trial frame with the refractive correction, and the other eye is occluded. This is the occluder, and starts reading the visual acuity chart from the largest letter down to the smallest that can be visualized. And if the patient cannot read this largest letter H, he is told to walk towards the chart, and at a certain distance, he will be able to see this top letter. And if this is at 3 meters, then the vision is recorded as 3 by 60. If it is 2 meters, then the vision is recorded as 2 by 60. If he is unable to read the top letter, even at a closer range, then the patient is asked to count the extended finger at about 1 meter, and the vision is recorded as counting finger 1 meter. If the patient cannot count fingers, the hand is moved in front of the eye, and he is asked whether he is able to distinguish the movements, and the vision is recorded as hand movements. If the patient is unable to see all these, then he is taken into the dark room, and a light is focused on the eye, and he is asked to say when the light is on and when it is off. If he succeeds in this, then the vision is PL, which is perception of light. If the patient indicates the 4 directions from which the light is directed, like up, down, right, and left, then it is recorded as PR, projection of rays, accurate or inaccurate in each quadrant. If he fails to see the light, then the vision is recorded as no PL. Another important thing is that if the patient is unable to read the visual acuity of 6 by 6 and reads only up to this line like 612, then it is necessary to look for improvement with pinhole, which can be made at bedside with a small cardboard with a central opening of 1 to 2 mm. And if there is improvement when the patient looks through this hole, then it indicates that there's a refractive error, and complete diffraction is mandatory in such cases. Variations in the Snellen's chart for patients who are unable to read include the Landau C and the illiterate E chart, which allows testing of visual acuity based on the orientation of letters. Other charts with better specification include the ETDRS and BDNL. Testing for near vision can be done with the Snellen's near vision chart, Jagger, or Roman test types. The near vision is tested by placing the chart at about 33 centimeters from the patient eye with the reading correction, and the maximum smallest text the patient is able to read is recorded. So if the patient reads only up to this line like Puruklai Vilayada Tharadir, then the vision is recorded as M18. In children, measurement of visual acuity requires expertise and patience. More time should be spent with them in order to create a cordial atmosphere. Vision in children is tested by response to light stimulus, whether the child fixes and follows the light. Other additional clues to evaluate vision are ability of the child to recognize faces, pick up objects, or move freely in the examination room. This is the optokinetics nystagmus drum, which can be used to assess vision in infants. The drum is rotated and the patient is asked to look at it. It elicits a jerk nystagmus with a slow phase following the target and a corrective jerk in the opposite direction. And the degree of visual acuity can be assessed based on the size of the target, this black stripes. Preferential looking test and VEP can also be used to estimate vision in infants. For older children, several pictorial charts can be used. This is the Cardiff card for children of 2 to 4 years of age. This is the Teller acuity testing, where the child looks at an object with a pattern stimulus, nothing but the black and white stripes, then a homogeneous field, by decreasing the thickness of the stimulus and presenting either on the right or left. Until the child no longer prefers to look at them, the visual acuity can be determined. This is the Lear figure testing. Here the child is given a card with 4 symbols like apple, circle, house, and square, and he is asked to point and match the figure which he sees in the monitor at a distance. The figure size in the monitor varied until the visual acuity is determined. This is the HOTV chart, which is similar to the Lea symbols. So vision testing at bedside includes the Rosenbaum pocket vision screening card, which is placed at a distance of 35 centimeters. Patient should wear the spectacle correction and each eye is tested separately, and he starts to read the optotypes that he can see. If he cannot see the numbers, then he is asked whether he is able to recognize and count fingers or hand movements. Another chart which can be used at bedside is the handheld Snellen 3-meter chart, which is used similar fashion. And there is an app which can be downloaded from the Google Play Store for vision testing. It's called the Peak Visual Acuity app, and here's a video of how it can be used. So the left eye is covered, and the examiner stands 2 to 3 meters away, and make sure to hold the phone at eye level. And he has to, the letter E is shown on the phone, and the examiner swipes the phone in the screen in the same direction as patient points, even if the answer is incorrect. If the patient says he cannot see, then the phone is shaken to record this. So we watch only the patient's response, and there's no need to look at the screen. The phone will finally vibrate when the test ends, and it also gives a score, and this can be used at bedside. So moving on to color vision, its testing is important as color vision is a salient function of the optic nerve. It can be affected in disease of optic nerve and macula. One differentiating point is that in optic nerve disease, even mild vision drop, the degree of color vision impairment may be severe. And in macular disease, the degree of color vision impairment is proportionate to the dyschromatopsia. And color vision defect can be congenital or acquired. So congenital color blindness is mostly red-green defect and commonly seen in males. And patient may not be aware of this condition, and hence when testing with the color vision chart, if the color perception is symmetrically affected in both eyes, then congenital color blindness should be suspected, and they are stable over time. There are different charts for color vision, and one is the pseudo-isochromatic plate, which is a book contains a series of colored plates, and Ishihara chart and Hardy ran with the chart are the examples. Next is the arrangement test, which includes the Francis 100 fuse test and D15 test. And then there's an instrument called the anemonoscope, which is used for color vision testing. So now let's see the Ishihara chart. It is commonly used to assess color vision in day-to-day practice, and it's a simple screening tool which can be performed rapidly at bedside. And testing is done one eye at a time, and the 10th edition contains 38 plates, and the plates are held at a distance of 75 centimeters perpendicular to the line of sight. And this is a test plate, which is the first plate in the Ishihara chart. If the patient fails to read this plate, then he might have a severe vision impairment of less than 6/60 or a dense central scotoma, or he may have a cortical visual impairment where he may not be able to group the dots to perceive the numbers, like in posterior cortical atrophy form of or if the patient is malingering, because even a color blind person or a person with visual acuity of 6/60 will be able to read this first chart. So let's see the design and function of the pseudo-isochromatic plates. This is the introductory plate, which we already discussed. This is the transformation plate. Here, a number is seen by a color normal, but appears different to a color deficient subject. This is the vanishing plate. Here, a number seen by a color normal, but it cannot be seen by a color deficient subject. This is the hidden plate. Here, a number cannot be seen by a normal person, but it can be seen by a color deficient subject. This is a classification plate, which is used to determine the type of deficiency, either red or green. And this is the pathway plate, which is used in illiterate patients where the patient places the line. So how to interpret? Of the 1 to 21 plates are used for screening red-green defects, of which if 17 or more plates are read correctly, then the color sense is regarded normal. If 13 or less plates are read correctly, then the person has a red-green defect. And the disadvantage is that it does not test for tritanopia like blue-yellow, and nor does it grade the degree of deficiency. For bedside testing of color vision, simple test is by asking the patient to report any change in the color appearance of a colored target like a red cap bottle, viewing first with one eye and then the other. Patient with unilateral optic neuropathy may report that the target looks paler or bleached with the affected eye. But if both eyes are affected due to optic neuropathy, then this intraocular comparison may not be possible. This is a Holmgren wool, which was used earlier to detect gross color vision defects, It consists of skeins of colored wool from which the patient is required to make a series of colored matches. This is the HRR chart, which is more accurate and used for testing both congenital and acquired color blindness, and it accesses color vision for all three axes like proton, neutron, and triton. And the recent version has 24 plates with 1 or 2 symbols in each, like cross, circle, or triangle. And the patient should report the symbol being perceived and its location. It helps in classification of patient with as a mild, moderate, and severe color vision defect. A more specific test used in office is the Frankfurt-Munzer under-tube test. It consists of 85 colored caps, which is divided into 4 boxes, and the arrangement of caps are performed 1 box at a time. In each box, there are 2 reference caps at the end that are permanently fixed to the box. The patient is asked to, the rest of the caps are taken out and scrambled, and patient is asked to place them in an orderly transition of view from one reference cap to the other. The caps are numbered on the back, and the scoring is determined by arranging the caps in the box. So this is a FM100 test result of a patient done with the right eye, and we can see the 85 cap hue, and that forms a colored circle in the visual spectrum. This is the cap order of the patient, which is fed into the computer software to obtain this plot. And here we see that the patient mostly has arrangement errors in the blue-green spectrum. And this is the D15 test, which is a smaller version. It contains 15 caps, and here there's a reference cap which is fixed to one end of the tray, and the rest of the caps are scrambled, and patient has to arrange in an orderly transition of view. Patients with normal color vision or mild color vision defects will arrange correctly, while patients with moderate to severe defects will confuse colors and will produce arrangement errors. So this is the Nagel sononoscope, which is based on a Rayleigh's equation that yellow hue is obtained by mixing red and green, and instrument has a light source which is split into spectral colors by prism into a circular field, and in the lower half the yellow appears, and in the upper half the patient has to adjust to match the lower half. So it is excellent test for screening, classification, and grading of color vision deficiencies. Moving on to visual fields, perimetry is an important tool in ophthalmology to assess optic nerve function, to know the extent and shape of visual field loss, provides diagnostic clues which will aid in localizing the lesion on visual imaging, and also useful in follow-up over time. It can be done by 2 methods, static and kinetic. In static, the stimulus is held constant while the intensity is varied. The examples include the Humphrey octopus and Goldman perimeter. And in kinetic perimetry, the intensity and size of the stimulus remains constant, but the stimulus is moved from a non-seeing area to a seeing area. Examples include tangent screen and Goldman perimetry. Coming to the bedside perimetry, which is a well-known confrontation approach, it is a rapid simple screening test, and here is a small video.
The patient is then asked to cover one eye, and the examiner covers his eye directly opposite. The patient is instructed to look directly towards the examiner's open eye, and fingers are presented in each quadrant, and the patient is asked to report how many fingers are being demonstrated.
So here the patient is seated at a distance of 1 meter from the examiner. Patient occludes one eye and is asked to maintain fixation on the examiner's nose. The examiner covers the same side and he compares the patient's visual field with his own. A series of stimulus can be used to test in the 4 quadrants and make sure that the patient is fixing on the examiner's nose and not searching for targets with eye movements.
The patient is then asked to cover one eye.
So one stimulus is the hand motion, where the examiner holds the hand within 1 quadrant and waves it from side to side and asks if the patient sees something moving. Next is finger motion, where the examiner wiggles the index finger rather than the whole hand. And the other is the finger counting or finger mimicking, where the examiner holds a closed fist in 1 quadrant and then raises 1 or 2 fingers briefly. Patient should report whether he sees 1 or 2 fingers, or he can mimic with his own finger if he cannot reply verbally. Next is hand comparison, where the examiner holds up 2 hands in 2 different quadrants and asks if one hand appears dim or faded compared to the other. And the other is a color comparison, where the examiner uses a bright red target as a stimuli and asks if the patient say whether the target appears faded or dim. Another form of confrontation is the double simultaneous simulation, and here's a video.
That one.
Okay, look at me.
That one. That one.
So the visual fields will be normal to confrontation, but if comparable visual stimuli are presented simultaneously in the right and left hemifields, that is double simultaneous simulation, the one contralateral to the lesion will be ignored.
That one. That one.
So the patient here ignores the finger to the right of the examiner. And this is a visual neglect most commonly seen in patients with parietal lesions. So confrontation can also be used to detect central defects, like when patient fixes on the examiner's nose, he's asked to say if there's any blurry, darker or missing areas on examiner's face. For confrontation in infants, a startle response can be used. And for older children, finger mimicry, as described earlier, can be used. The disadvantage is lack of standardization, the qualitative nature of the result, limited ability to detect subtle defects, and inability to monitor progression or remission of the field loss. And this is the Amsler test, which is a rapid screening test to assess the central 20 degrees of visual field. Patient views a chart with a grid of horizontal and vertical lines placed in the reading distance with a spectacle correction and records response directly on the chart. One eye is tested at a time, and the patient fixates on the central dot, and he is asked to say if the lines surrounding appear straight or wavy or distorted or if any parts are missing. Maculopathies typically cause image distortion and central scotoma, which can be easily detected by the simple test, which can be done at bedside. And this is the tangent perimetry, which is not commonly used these days. For want of time, I'll just tell the disadvantage is that it's strong dependence on the skill and technique of the perimetrist, lack of standardization, and its difficulty to monitor patient fixation, and the lack of normative values. This is a Goldman's perimeter, which is the which has a white hemispheric bowl and onto which a small bright stimulus is projected. It can be used for kinetic and static as well. And the advantage is that the Goldman perimeter can cover a large eye software extending about 90 degrees temporally and 60 degrees in other quadrants like full field, unlike the Amsler or tangent testing. And it can be used in children and elderly because the perimetrist can monitor patient's eye position and can interact with the patient to maintain fixation. The most popular form of visual field testing is the static perimetry, and most often performed with automated perimeter like Humphrey Visual Field Analyzer or the Octopus perimetry. The advantage include its standardized testing procedure, and it has an age-matched normative values, and is useful for follow-up and for comparisons. So how is it testing done? This is a Humphrey Visual Field Analyzer, and patient looks at a small fixation point in the center of the white hemispheric bowl, and a light stimuli is presented briefly for about 200 milliseconds at fixed stationary location, and the patient presses the response button when the stimulus is detected. So we use the 30-2 program, which tests about 76 points in the central 30 degrees, and it is said that nearly 80% of the visual cortex correlates to the central visual field, and hence testing the central 24 or 30 degrees of visual field is sufficient for most defects. So this is a HVF printout, which is divided into 10 zones for better understanding, and the testing takes about 4 to 8 minutes to perform. And this is the Octopus perimeter, which this is the printout of the Octopus perimetry, and it is slightly different from the Humphrey Visual Field Analyzer. So interpretation of visual field should go hand in hand with the clinical findings. The disease of not only the optic nerve but also retina may produce field defects. Like for example, a macular lesion can cause central scotomas, a retinal artery occlusion can cause focal defects, or a constricted visual field not involving fixation is seen in retinitis pigmentosa. So it is important to look at the fundus to correlate with the visual fields. And these are a few examples of visual field defects and its clinical conditions. And this is the bitemporal hemianopia, and this is a picture of a right pine floor defect. The one is the inferior archtitudinal defect, and the central one is the peripheral constriction seen in retinal dystrophy. To conclude, in the general neurology setting, neuro-ophthalmic examination can be rapidly done, needs little instrumental equipment, and can thus guide to more sophisticated diagnostic investigations like neuroimaging, LP, and additional tests. The essentials, including testing of visual acuity, fields, and color vision, which can be done at bedside with few simple tools that will aid in examination. Thank you.
It was a wonderful lecture, Dr. Padmalakshmi. Very informative. Thank you very much for the effort taken to do this lecture. Thank you very much.